So just mentioned before, we have a lot of patients nowadays because they have to have a AV block. So this patient, we just have begin our talk from a case. This is one patient, a 55 years old woman, and she was referred for DDD implantation due to AV block 1 year ago. So she felt short of breath and dyspnea because she felt very tired. And she come to our hospital, and we found the edema of extremity of his two legs. And we just mentioned what's his definition. Let's check his X-ray. We found his RV lead is located in the apical, probably a bit lower septal, and echo showed us a severe and moderate mitral wave regurgitation, and LVEF by plain method is 34. And we also found, because this echo doctor is very experienced doctor, she found a reduced activity in the middle segment of the left ventricular inferior wall. Very interesting. So we just wonder if she's PICM, pacing-induced cardiomyopathy, or unpure or unpure. That means, because we just wondering if it's some special cardiomyopathy before implantation. That means 1 year ago we checked his ECG and echo because she just transferred from the relative, so it's not very clear. We found the troponin I is elevated, and the CTA is negative, and also his heart failure. Also, the LVF is 44. That means she has heart failure 1 year ago, actually. And during 1 year RV pacing, because she almost 30 complete AV block, so the LVEF is reduced by 10%. That means from the 44 to 34. So from definition, it's a defined PIC, right? Let's continue. And we found the ECG 2, 3, and AVF is I think it's a bit lower septal, and also the care duration is 189 milliseconds. So we just define the PIC. There are 3 definitions. If the patient have LVF larger than 50% at baseline, and during follow-up, the LVF is less than 40, and the patients have LVF less than 50, that means 44, and during follow-up, the LVEF reduction larger than 10%. So no matter of the baseline LVEF, and the LVEF reduction larger than 10%. So from this point of view, I think she is defined PIC. But we just wondering why? Because baseline LVEF is 44. And from this PICM, because there are no definition of unpure or pure PICM, mostly patients have the larger percentage of RV pacing percentage, and the KRS duration is wide. And also we have to exclude other reasons. So there are 2 questions we have to consider: how to handle, and second, this is a pure or unpure PICM. That means we how to upgrade. So choose CSP, that means L left branch pacing, or biventricular pacing, or what kind of D or P, because only 1 year do a DDD. So if you choose CRTD, probably it's more expensive, right? So we just discussed with his relative. And also we just wondering, because the left LVEF is 44, so we just mixed cardiomyopathy. That's our question. So from the guideline 2021, we just find the imaging guided recommendation. We just found here, see, myocardial fibers on CMR, probably we have to implant CRTD, and also we have to consider the patient age, and also he recommend here, if the patient has non-ischemic cardiomyopathy, we probably choose CRT. And this is a patient because CTA is negative. So from this view, we have to upgrade to CRTP, right? And also this is a very young woman, not very old. So, so from this view, we have to choose CRTD. And also this is very health and another poor renal function and patient preference. And we discussed with his relatives, and they choose CRTD. Actually, we don't know which one to choose, honestly. So we just choose. We use CMR scan. This is our choice, right? Because we think CMR have advantages. Let's just choose scan. So this patient has A3, that means CMR considerable. A3, that means from Medtronic, and we use this patient, we use this special sequence for scanning. We found here, you see, the thing that's not very loose. And continue. And this is a 4-chamber and the 3-chamber because they're lead, so some mixed those. You can see very clear. And you see here, from short axis, we also found here a bit dyspnea, right? And we also continue our scanning. And this is LGE, that means injector guardian, and we found here LGE in guard enhancement. Here, see? That it is just comparable to the echo result in left ventricular inferior wall scar. That is, but the patient is non-ischemic cardiomyopathy, but she has ischemic scar. Very interesting, right? So we just wondering, this idea from probably it's the sarcoidosis. Yeah, this is very, very, very strange, but I have this idea, right? And we show our scanning here. We also found scar ischemic transmural scar here. So this people is very lucky because she had CMR scanning before upgrade. And we do all the scanning, and we check all the scar there, and only find the inferior wall scar, ischemic scar there. Before I upgrade into implantation, I just checked X-ray. I found a multiple lymphodenopathy in medial sternum. I just have a good idea. Probably this patient is sarcoidosis. Again, come to my idea. So we choose CSP, and also we choose CRTD. And we would like to do some special. We want to do endomyocardial biopsy at that time during our implantation. And this the implantation is very successful, and we found here because we do the implantation. I just choose the 3830 lead to include the lead to the middle segment, and we found the apparatus change from the 78 milliseconds to, and we found the potential here, and we finally implant the L3830 lead, and we do the 3830 lead, and also we put in ICD implantation, and also we just remove the RV lead. And this is ECG before and after the implantation. I found these 2 and 3 leads because it's elective, so a bit lower, honestly. But because this patient are upgrade, so we can put a very high in the segmental. This is a bit a drop. And one month later, we found LVEF from the 34 to 38.9%. So the patient felt better and relieved. And to the EMB, cardiomyopathy result in the histochemistry, the CD68 is positive. That means granule inflammation there. So it's the brown the brown lead here, it means the granular cells and organized, then is supportive of sarcoidosis. So we asked the pathology doctor. They told us, yeah, it's a sarcoidosis, but we have to check this one, right? So we asked the patient because she has coughed sometimes. So we refer for lymph nodes echo and also found some lymph nodes swelling. And we asked, tell the people to the respiratory department, but she refused further treatment. But the pathology result also support of the sarcoidosis. And also the ACE is high because we do the ACE at that moment. So at this time, we just make the decision. This patient is sarcoidosis, but the patient refused for treatment. So he just we do the follow up during 1 year. Let's check the guideline again. Because we think here the patient have the CRT or CSP. That's a big question. From the ESC guideline and also from the CRT guideline and also to the HIS guideline, we found some different opinion. But the patient have to be upgraded because the patient is defined the PICM from the EF reduction, right? So we choose the LVBP implantation. And from this point of view, we found here, PICM, if the patient have less than 35%, we use the CRT, we buy V, or we can use the CSP. So from this point of view, we choose the LVBP. And this is our group study. From multi-center study, we choose LVBP to upgrade PICM patients, and we found the patients have very high response. So we choose CSP, right? But to the CRTD or CRTP, because according to the CMI results, we just use the CRTD. But honestly, before the upgrade, we don't know the patient is sarcoidosis. So we'd like to say the multimodality imaging is very important. And as to the scar and sarcoidosis with AV block, here they found scar and associated fibrosis leading to BTS. I mean, the patient, if have a scar, we'd like to recommend the ICD to such kind of patients. And we also use the FDG. Honestly, to this patient, we also scan the FDG because we have to check the patient because we don't want to diagnose this patient sarcoidosis or not. But we do some study because for such patients, PICM, we have to find is that pure or unpure PICM. And we found this patient have the inferior scar, and also we found here the metabolism is a bit lower. And after upgrade, this is before the upgrade, and this is after upgrade. The metabolism here is still very low, but here the septone is a bit higher, elevated. That means the patient dystony is a bit elevated. So that's why the patient has elevated LVF before at the beginning, but later because the sarcoidosis progressive, the patient have the decreased LVF. We'll show the results later. So assessment before the implantation, we have to do some multi-imaging scan to see if the patient have unpure PICM. We use the CMR. If the patient have the ischemic scar, we'd like to upgrade to D devices, ICD devices. And also, the patient have scar extent very high, we'd like to choose. But also, we have to choose an echo because the patient, the LVEF is less than 34, so D or P is okay for this patient. But as a result, the patient is sarcoidosis. If we don't upgrade the D, it's a big question because the patient will die from VT. Honestly, during 1 year follow-up, this patient have no VT. And to the SPECT and PET scanning, we'd like to see the metabolism and the FDG, like diffused or not, or reduced or not, because we'd like to choose such kind of patient. And during 1 year, and because the patient from the 34 to 38, and then she has a short of breath again. So then she like to for the sarcoidosis treatment. At the beginning, she refused, and later, because she had a shorter breath again. So we choose. And this patient, 3 months ago, she come to my department. She told me, okay, she felt better, but the LVEF is not elevated very good, well. But honestly, in our patient, for example, the pure PICM, the patient have elevated LVEF 1 month, I mean, very, very quickly, almost complete recover. And second case we'd like to show, because just another professor showed us TR, the big question. And this patient is also because she is tightness, short of breath after pacing for 6 years, and she have the chest cavity regurgitation worsens. We'll show here because the lead is pressed to some posterior valve. And this patient, we'd like to remove the lead at the beginning, but the patient have 39 degrees just 1 minute before our operation. It's very interesting, so we stop her surgery. But honestly, we'd like to check if the patient have the vegetation, because we wonder if the patient have the infection. So we do the TE two times, but no vegetation. But he can't resist TE, so we don't do this one, and we checked the guideline. We found the other, that means FDG, PET, because there's a guideline showed us we have to use the other imaging method to check the patient have the infection. So we do again the PET, and we found here show us, because in the normal atrial there are no uptake of the tracer, but this patient here, the right atrial lead seeing some uptake. So we just wondering if there's some infection in this patient, because we don't have the culture result at that moment. So we decide just waiting for the culture result. But you see here, almost all the apical cardiac, the left right atrial, there is uptake of the FDG. So it means the inflammation, and also there's the culture result showed us is the cochlear is positive. So from this guideline, we show us the FDG is, and also the positive blood culture. So the patient have to remove all the leads there. So it's a different strategy for this patient, because at the beginning we just remove and implant other lead. But the patient at the moment is defined as the CIED infection, so we just remove all the lead. So the patient after lead extraction, the TR improved, temperature controlled, and no obvious chest tightness or short of breath. So, inclusion. For such kind of patients, if we want to upgrade patients, we have to do multi-mortality imaging. And also, sometimes we need endomyocardial biopsy. It's also needed. And also, we have to choose DOP for such kind of patient, because only 1 year implantation. So it's a very difficult challenge. We have to make a decision for such kind of patient. And also, if we wonder if the patient have infection, we have to do a multi-mortality imaging, because every imaging have its advantage and disadvantage. So that's for such topic. Thank you so much.